So, Carol, it's been a very interesting and exciting meeting about breast cancer prevention. And as we would both agree, I think breast cancer prevention starts with estimating risk. And there was a very interesting presentation this morning about mammographic features of benign breast disease. What did you think of that?
I think there are things about that presentation that need to be looked at a little more carefully. But the finding that women with proliferative breast disease that have calcifications in their mammogram, even though they don't have atypia, may be at increased risk, especially if they're young, I thought was very exciting. And so maybe that is a type of proliferative breast disease that really should be considered for supplemental screening or possibly prevention interventions.
Prevention interventions, exactly. And so, as people who advise women about breast cancer prevention options, we really have not had data so far connecting the benign breast lesion and the histology with the mammographic features. And the Breast Cancer Surveillance Consortium data are really particularly well poised to do that, since they have very large numbers and they have lots of mammographic detail. So that's actually really good use of that data, and I was happy to see them do that.
Well, speaking of risk, in another session on prevention, the speaker presented a lot of data on polygenic risk scores and how we might use it to clarify what someone's risk might be. And it seems particularly useful in women with moderate penetrance gene mutations, such as ATM and CHEK2. So again, that might be very helpful in determining, one, who's at high enough risk to warrant supplemental screening. Two, in terms of moderate penetrance gene mutations, who can simply take part in screening or prevention drug, or who's really at high enough risk that prophylactic mastectomy should be considered.
So the polygenic risk score data are very interesting, of course, and there's a huge amount of data that's accumulated over the last few years. The problem that I see in applying that information is the fact that there are a myriad scores. And so it's very hard to know which is the appropriate score in which setting. And in that discussion, it came up several times that most of the scores are based on a homogeneous population of European descent, white women, and the degree of information that's available for non-white women is actually quite scant. And so there's a lot of work to be done in that area, but I think the directions that you pointed to are encouraging. And although it's not clear to me that it's really ready for clinical use at the moment, it's going in the right direction for sure.
Another presentation this morning by Dr. Jack Kuzik, looking at data from the anastrozole versus placebo trials. He looked at bioavailable estradiol levels, and those women that were in the lowest quintile of bioavailable estradiol did not benefit from anastrozole. So he is encouraging women as well as their providers before they start on prevention anastrozole to actually check those estradiol levels. And I think that paper is out in Lancet today.
Today, that's
So
right, yes.
I really would encourage people to look at it.
Right. I think that the caveat about the data, though, that I've discussed with him is that they are using an HPLC, a high performance liquid chromatography method, to measure the estradiol. And so those methods are not universally available. And the trick, of course, will be to set thresholds with robust reproducible estradiol assays, because the idea is to not offer prevention medication, particularly aromatase inhibitors, to women who are in that lowest level of available estradiol.
The hormone and obesity sessions were very well attended. Some great questions on some sticky topics. And I think the takeaway messages is that for most women, unless they do have invasive breast or uterine cancer, hormone replacement therapy, if they have moderate to severe symptoms, are not taboo. For estrogen alone, there really is probably no increase in risk for breast cancer taking it for 5 years or less. And there may actually be a small decrease in risk for conjugated equine estrogen. On the other hand, if you have a uterus and you have to take estrogen plus progesterone or estrogen plus progestin, there's probably about a 30% increase in risk with 5 years of use. And in that regard, use of a new combination drug, the combination of basidoxifene, which is a SERM, and conjugated estrogen is very effective in relieving vasomotor symptoms, and it does not increase risk for breast cancer. And in fact, we are actually looking at it as a chemoprevention agent. And Dr. Kilcarney from your institution is also looking at it in ER positive DCIS.
Right, that trial is actually about to close, and we should have results by the middle of next year. That'll be very, very interesting data. It's postmenopausal women, of course. So the combination of estrogens and progestins are obviously have been used for decades for oral contraceptives in premenopausal women. So do you see any role for the application of an agent like basidoxifene with conjugated estrogens for premenopausal women?
Um, I think that's a real possibility, especially people that have several uterine problems like endometriosis or
Right.
fibroids. We're getting a signal that our time is running out. I do just want to emphasize that the obesity session was great. We had a couple of discussants talking about the potential of incretins because to really get substantial risk reduction, women probably have to get a 10% sustained loss in body weight or somewhere around a 20% decrease in visceral fat. So all around a great
Yeah.
beginning for prevention at this meeting.
Absolutely, yes.